Hello and welcome to Wound Masterclass. This is a globally accredited masterclass on pressure injury prevention. We're delighted that you're going to spend the next hour with us and three of the world's leading experts in pressure injuries. This is a fully interactive experience today. You'll have a chance to visit the exhibitors hall, which is here on our left, and here you'll be able to find out a little bit more about some of the products that we will discuss. You can then go on to the auditorium where the interactive panel will begin. If you have any questions about the interface or the virtual chat on how to ask questions of the panel today, please visit the information desk, which is a virtual info desk, and you can ask any questions that you have. The interactive element allows you to ask questions of our global panel, and you do this by going to the top right of your screen where there is a Q&A interactive chat option. So welcome to our global audience for our next Wound Masterclass event. Tonight we've got From Consensus to Clinic, Strategies for Pressure Injury Prevention. And I'm delighted to be joined by this stellar global panel. They really need no introduction. We've got three of the leading experts in pressure injury prevention. I'm really honored to have you all join us on this panel. Welcome, ladies.
Thanks. We're excited to be here. I know I am.
And for the viewers that are watching at home, don't forget that you can watch this on demand. It's going to be on Apple Podcasts, Spotify, and SoundCloud. There is a CME and CE and EBAC accreditation at the end. You just need to scan the QR code and the certificates will be sent out to you within 10 days. So to start off with, Kathleen, I'm really excited to hear your experience about understanding pressure injuries. So starting right at the beginning for our global audience, you've had a lot of experience in this and you're a world leader.
Well, thank you very much. Really, what I want to spend time with, the time that I have with you, is really setting the stage, understanding what are the stages of a pressure injury, what their impact is to our health systems, to the patients themselves, and then the challenges that we have in early detection of patients potentially developing a pressure injury. So that's what I'm going to focus on.
That's amazing. And we're also excited to hear from the rest of the panel about their opinions. So for you in the global audience watching us at home, if you have any questions at any point, we'd love to have you join the conversation. We can use the text Q&A, or if you want to leave a comment about your current practice, it's the box to the top right of your screen. If you want to watch this in a different language, then you just need to click on the CC icon, and we've got 20 language live translation. Great. So let's get started, Kathleen.
Awesome. I appreciate it. I do have these disclosures to put forth. I am sponsored to present for this presentation by Bruin Biometrics. I'm on their speaker bureau and these other companies, but I'm also an expert with the American Hospital Association on pressure injury prevention. And I'm very proud to say I'm a board member of the National Pressure Injury Advisory Panel. So I'm teaching, you're going to get objectives. I want to identify the various stages of the pressure injuries, discuss the global financial and clinical impact of pressure injuries, and then really delve into the challenges of early detection and how we might use technology to make it easier for us to identify patients at risk of potential of development of the pressure injury. So always, it's good to start with a baseline of a pressure injury definition. Pressure injuries or ulcers, depending on what part of the world you live in, are localized damage to the skin or underlying tissue that's usually over a bony prominence. That's a real key component in the assessment, or related to a medical or other devices resulting from prolonged pressure or pressure in combination with shear. The lesion can be present below intact skin or an open ulcer, which may be painful to the patient. So there's this concept of a pre-stage one. Are there visible signs of pressure injury that have not evolved yet? So, for example, do you have a boggy heel? Do you have blanchable erythema? Is there an indentation because of a medical device? Could there be ischemia noted from a thermographic scan? Or could we be identifying injury because of it seeing increased subepidermal moisture? So it's almost this concept of could we pre-stage what we can't see necessarily, any damage yet? So what happens when we start the staging process? So there are 4 stages: unstageable, and deep tissue injury. And stage 1, pressure injury, is a non-blanchable erythema of intact skin. Now, needless to say, I'm on a, on a webinar with you, so I can't really blanch what's on the screen to show you that it's non-blanchable. But if you remember, this is where you stick your finger into an area of redness. And if the redness doesn't change, that is non-blanchable erythema. Now, that may be different in darkly pigmented skin. Those are one of the challenges we're going to talk about later. The color change does not include the purple or maroon discoloration that you see with a deep tissue injury. So just to give you an example, here's my chance of trying to blanch it on the screen for you. The stage 1 pressure injury, this was discovered on tissue that had been exposed to pressure in combination with shear, which can happen at patients lying in bed, and then we move them up with a non a, a sheet where it isn't friction reducing, and we end up getting a combination of shear and pressure. The patient was lying supine when the pressure injury occurred. It's located on the buttocks. You can see you've got some buttocks, but you also have a little bit of the sacrum in there. And this fold linear mark can literally be a tubing present or linen that was folded that could create that type of injury. It's been known to happen if the patient stayed in that position for an extended period of time. Then stage 2 means we're actually broken through the skin, partial thickness skin loss with exposed dermis. So, and by the way, that's why stage 2s are more painful, because they're in the area where the nerves are. So it causes more discomfort for the patient. The wound bed is viable. It's pink, usually moist. It may be an intact blister or a ruptured blister as well. You shouldn't be able to see, and I'm going to see if I can get my pointer going here. You shouldn't be able to see the subcutaneous tissue or any muscle. And you see granulation. You may see granulation, but slough, eschar, not present at all. And these injuries commonly result from not having the right microclimate. In other words, excess moisture in the area, shear to the skin. So you're also going to see this at the heel area, hips, and the sacrum. And just to give you an idea, one of the this is stage 2 is probably the most inappropriately diagnosed stage, because our incontinence or moisture associated dermatitis ends up being in similar areas that make it look like a stage 2 pressure injury. So you can't really stage something like this. Do you see how irregular that is? And it's not over a bony prominence. This is moisture associated. This is incontinence associated dermatitis caused by urine or stool. And then you have the moisture under the breast tissues. We don't normally classify that as a stage 2, but sometimes skin tears get classified. So again, looking over is this area over a bony prominence? Does it meet the other criteria? So you need to be able to rule these out before you rule in a stage 2. So again, is it incontinence-associated dermatitis or is it a stage 2? Moisture-associated dermatitis is common in elderly patients, but I got to tell you, the incontinence-associated dermatitis rate in ICUs runs about 36%. And incontinence itself in our acute care around the world. There have been 3 very large epidemiological studies showing 42 to 53% of the patients in an acute care hospital are incontinent at some point. The skin gets macerated by the exposure. There are chemicals in the urine and stool. It becomes inflamed. Wound can develop over time. And by the way, your skin, there is a direct correlation by having incontinence-associated dermatitis that you're likely going to get a pressure injury because the skin is massively weakened. So how do you make a determination that I'm dealing with one or the other? Is there a history of incontinence? Are the wounds shallow and are they diffuse around? So you can see that diffuseness here versus what you're seeing up here, the diffuseness as a part of it. Is it on body parts that fluid could reach? And does the skin smell like ammonia? Sorry, pneumonia. Thinking of something else. And then gluteal cleft wounds. They're seldom pressure induced. It usually has to do with moisture and the friction that occurs between the gluteal folds. But I got to tell you, they frequently get labeled as a pressure injury. How do I make that determination? If the patient's obese. So that occurs around in between adipose folds. Is the patient difficult to move from side to side? Are they diaphoretic so that you've got a fair amount of moisture happening? You should label this as moisture-associated dermatitis, the gluteal cleft wounds. And that moves us. So I'm really honest with you. People have the most difficulty on the stage 2 because of these other components that occur related to moisture or friction and moisture that contribute to a different diagnosis, but it may look like a stage 2. When we get into stage 3, you can see through the picture here, we're now into the subcutaneous tissue. So it is a full thickness skin loss in which the adipose or fat is visible in the ulcer, likely to have granulation tissue present. You may have rolled edges as well in the wound. And there may be slough or eschar visible. Slough is that yellow material that's covering the wound. And eschar is the hard black. One of the things is if you have eschar or slough in the wound, it then becomes unstageable because with that on top of the wound, you can't see the depth of the injury. And if you can't see the depth of the injury, it makes it difficult to stage. I hope that makes sense. This is also when you want to poke around. I know, put a glove on, poke around the wound to see if there is undermining, which is no tissue under surface skin. So there's nothing connecting it. Or you also want to feel around for potential pockets. And then you grab a Q-tip and see if you have undermine or if you have tunneling taking place. So here, remember the muscle, the tendon, the ligament, the cartilage, and the bone are not exposed. So remember, slough, eschar, obscures the extent of the injury of the loss, so it then becomes an unstageable pressure injury. So here's some examples in the ischial area, in the sacral area, and the heel. And this almost comes close to being an unstageable, but you also know that the heel doesn't have a lot of tissue there as a part of it. And when we move into stage 4, you go all the way down to the cartilage, the bone. It is also a full thickness wound. palpable fascia, muscle, tendons, ligaments, cartilage, bone. Oftentimes, again, taking that gloved hand, feeling the base of the wound, because sometimes you may not see the bone, you may actually feel the bone. And you also may have those rolled edges that we talked about. Again, with a stage 4, you need to be assessing for the undermining as well as the tunneling. And again, if you have slough or eschar, you cannot determine the stage of the wound and it goes into an unstageable. So this gives you here, and there is enough here for me to tell because I can see tendon. So that tells me, and I got bone right here, and there's a tendon. So that gives you an idea that even though I may have some slough, I can see the injury area enough to be able to say it's all the way down. So that's the unstageable component. Now you see this one. I I've got some muscle here. This is probably not the best unstageable picture, but this part of the wound, which may not go as deep, I may not be able to stage that because of the eschar tissue. So when it is obscured, so it's usually a stage 3 or 4, when it is obscured by slough or eschar, you can't stage it. Stable eschar, specifically on the heels, you really shouldn't touch. It shouldn't be softened or removed because it's serving as a protective mechanism. That's an example of an unstageable but of eschar, but I would want to leave it there as a protection. Here's another unstageable. This is probably a much better picture of an unstageable. I can't get at how deep that wound is. And that's really, you're looking for the depth of the injury, and the same here. And hopefully you guys are putting questions in the box as we go along if there's anything that doesn't make sense to you so that I'll able to answer them throughout the various presentations. So a deep tissue injury is a persistent non-blanchable. So there's that non-blanchable term, but the biggest component of deep tissue injury is the maroon or purple discoloration. That is the hallmark. It can be intact or non-intact with that local, persistent, non-blanchable, deep red maroon color. Now, the challenge is in darkly pigmented skin because sometimes it's very difficult to differentiate. So we may need assistance in evaluating that. There are often pain and temperature changes that occur before the discoloration shows up. This usually occurs from a very sharp, persistent um, pressure that has occurred. And oftentimes that may even happen before they ever come to us. And then 2 to 3 days into the hospital stay, this shows up and you're wondering, oh, how did this happen? And it came from this intense or prolonged pressure that occurred prior to ever coming to us at our healthcare facility. So these are some examples, and these are darkly pigmented skin. You can see the discoloration as a part of it. It is difficult to distinguish in darkly pigmented skin. The other piece that's important in deep tissue injury, as you're looking at this, you want to delve into the history and ask, there needs to be a clear kind of history that there was this intense or prolonged pressure. They were found down at the scene. They were in the OR for 4 hours on the table. They had a long stay in the ED, whereas in the trauma recess bay, then went to CAT scan, then went to surgery, or they were sitting in those jerry chairs longer than they should be as a part of it. It's also it's important to determine and differentiate deep tissue pressure injury from ischemic injury, like toes coming off and fingers, from vasopressor meds.
I'm delighted to come across to another global expert, Anne-Marie Nee, who's going to take us through head-to-toe assessment for the pressure injury patient. So, Anne-Marie, you're going to do a practical examination now to demonstrate those really important aspects of head-to-toe assessment.
So thank you so much, Nikki. I am so grateful to be here today to be able to explain a comprehensive skin assessment. Like Kathleen, I do have a few disclosures. I am currently the secretary of the National Pressure Injury Advisory Panel. I am the chair of the education committee, and I'm also the chair of the annual conference. So that organization keeps me a little bit busy. But the reason I do this is because I truly am passionate about preventing these wounds in our patients. They cause incredible harm, not only skin harm, not only financial harm, but psychological harm for the patient and for the family. And so we start everything with a really good comprehensive skin assessment. Now, as my colleagues have said, this is where we start. The SEM is a beautiful adjunct, but we've got to be able to use our nursing assessment, our nursing judgment as we continue down this road. So one of the first things that I also always like to tell my nurses is, first off, before you even walk in the room, make sure you have your supplies, right? Don't walk into the room, have to go back out. Make sure that they're with you. And a skin assessment is something that we perform within our daily task. It's not something I go, oh, I'm going to do my skin assessment right now. You have so many other things that you do when you're in that room. Make this just a part of your flow that you're going in the room for. So if you're going in for pericare, go ahead and do your skin assessment while you're in the room. If you're going in there for, you have to suction a patient who happens to be in the ICU, go ahead and take this time to do your skin assessment and make it just a part of your daily assessment as you're in that room. And the other thing to make sure of is that if you need additional staff members, make sure that they're already ready and they're going to walk in there in the room with you, or they're on their way. So again, if you've got an obese patient, you can't move yourself, you're going to have additional hands that you're going to need, or someone who is intubated, you're going to need your respiratory therapist in there. Gather everybody together, work as a team, and then it makes it a much more smoother transition to go ahead and do your skin assessment. So your first step in completing a full comprehensive skin assessment is, prior to coming into the room, you want to make sure you have supplies. So the supplies can be things like, if you're using the SEM, make sure you have it with you. If you know that the patient is incontinent, make sure you have all of your supplies for cleaning and new Depends or new nappy, and bring that with you. You don't want to be going in and out of the room while you're completing the skin assessment, because it actually creates a draft and the patient could be chilled. The other thing you need to think about is that if you know you've got a larger individual patient, try to have your staff members ready and bring them into the room with you so that it all can be done at one time. What you do is start the skin assessment in whatever position the patient is in. You don't want to start rolling and moving them around to begin with. So with our patient here, what we would do is, if she would potentially have on any medical devices to her face, that's where we're going to start. We're going to look at her scalp. We're going to look at whether or not she maybe have on a respiratory mask. So if I got a respiratory mask on and she's got around, I'm going to look underneath my cannula. I'm going to look at the straps. I'm going to look behind her ears, move her hair out of the way, and make sure that there's no discoloration there. Now, she happens to have on very beautiful earrings, and if our patient did have on that, I would actually be looking at that, because those earrings, if we had a mask on, that the strap caught those earrings, then you would see the indentation of this earrings. That could potentially be a pressure injury that we're looking for. The other thing with that, if they had on a medical mask at any time at all, you're going to look at the bridge of the nose. If you see any discoloration, check to see if it blanches or it doesn't blanch. You can also look at her chin area and make sure that there's no discoloration that is there. So the first thing, of course, is her head. From there, we're going to move to her neck. Can you lay back there? Very good. And so with her neck, we're also going to look, do I see any discolorations at all? Does she have on a C-collar? If there had been a C-collar on, we want to make sure that where the C-collar rests, which is usually on the upper chest, the chin area, also her ears, make sure there's no discoloration. If she has on a C collar, this extra staff members that you have with you, have them hold her, put her spine in alignment, and you're going to remove the top part of it and to do the skin assessment right here, check everything underneath that, and then you're going to put it back. As you're going through this, if you're noticing any discoloration and you have to put that medical device back on, make sure you have a foam dressing here within the room, and you're going to go on ahead and put that foam dressing down to her skin so that you're patting the area from whatever device you have to put back on her. From here, we would actually look underneath her breast area just to make there's no discoloration that are there. And with that part of the skin assessment, there's two things we could potentially be looking for. A lot of women who have larger breasts, they tend to hold moisture in the area, so we could potentially have a yeast infection that is there. Or sometimes with very pendulous breast, actually the weight of it can actually call pressure to that site, and so we want to make sure that we're looking there. The next, I'm going to move to her arms. So if we look at her arms, if she's come in at any facility at all, she will have had on a pulse ox at some point in time. So I would look at all of her fingers, and I know she hasn't had on a pulse ox, but this would be something, to me, would be a red flag, that little tiny red dot there. I would be looking at it to make sure that it wasn't from a pulse ox. And so to be clear, on pulse ox, many people say that those are burns. Unfortunately, I've actually had an electrical engineer test out pulse oxes. They do not have enough heat to actually burn the skin. If you see discoloration, look at it, see if it fits the size of the medical device, whether it's pulse ox or something else, and we know we've got some pressure components going on. Turn her hand over, because if she's got an IV, you want to look where that IV is at. Is the hub pressing into her skin? Are we looking for discoloration there? And if so, we want to make sure it's padded and protected. If recently an IV came out, look at the skin around it. Make sure that there isn't any areas that fit the actual dimensions of that IV, because then we are looking at a pressure component. As we continue to look at her skin, we're going down the body. So on someone we have in the hospital center, especially if they have on a brief of some sort, you want to make sure that you're looking at where the tabs and the diaper or the brief hits in the groin area. Those are very areas, lots of moisture in there, and they are very prone to break down from the elastic that hits in there very tightly. So you want to make sure that we're looking in this area when you're doing your full skin assessment. If she would have on a Foley catheter, the other thing that we're going to look on, and I'm going to move this down up just a little bit, is in her thighs. Because typically we like to secure them onto her thighs, but when we're doing that, if she's tight like this, then we do have patients who are contracted and they cannot move their legs open, so you want to make sure that you're looking at that whole line of that catheter. Do Foley care while you're at it, because why not? You're already here, let's just go ahead and take care of it, and walk your way down the line and look at the skin, because if we have any pressure, you'll see discoloration where it was at. If you move it, make sure that you do move it, come back to it and see if it had originally been non-blanchable, that it is now blanchable, and then we know we've got rebound hyperemia. So it's a precursor to pressure injury, but at this time would not be staged as such because it's non-blanchable. Head on down her legs, and if she had had any orthotics, you want to make sure you remove the orthotics to look underneath her legs to see where they would have stopped. Edges are really good for pressure on either ends of orthotics. Make sure you're looking at that, take it off, see it, and see what's going on. Coming down her legs, if she was one of my patients, this is an area I would be focused on. As you can see, there's discoloration here, and we would be asking the questions as to what caused it, what was there, did she trip, did she fall, did she have on tight shoes that came up and lace tied, did she have on socks that could have been laced there. So we always want to be a sleuth, asking the questions to find out where some of this discoloration is coming from. And then you can look at her toes and see what they're doing, if there's any discoloration to it of her toes. So at this point, we've completed her whole front. And so we're going to move her over to her side, and then we're going to go backwards from her toes up back to her head. With the help of staff, we went ahead and got her repositioned on her right side. So now what I'm going to do is look at the back of her heels. Heels are a very common location for pressure injuries, especially in teenagers and adults. So we want to make sure we do a really good skin assessment here. As you can see, we had a little conversation. She actually had a blister here from one of her shoes that you can see very clearly, but her skin here is of normal coloring, and so we want to make sure we're touching it, and you can see she's a little bit of redness. It's blanching, so this is all very normal. Now, if you've got your SEM at this point, you want to take it out and you want to use it on her heels. Look at that, see if there is a moisture component that's there. We're going to prevent pressure injuries if she is in bed and going to be for some time, so make sure you put down prevention measures at this time while you're here. We're going to walk our way back up her body, and as you can see, we're going to look through all of her back of her thighs. I don't see anything there. Up into her pelvic and buttock region. If she is incontinent of stool, you want to make sure that you're cleaning her up, or urine, clean and dry, so that you've got nice dry skin to look at. Once it's done and dry, again, pull out your SEM and go ahead and take your assessments here, noting the numbers. And if you're not really good at remembering the numbers, either turn around and write them down. If you've got a staff member in here, have them write them down for you so that can be documented on later. One of the things I want to caution you as you're down this way, I'm going to touch a minute here, is that in between her buttocks cheeks is what we call the gluteal cleft. When we're looking at the difference between a pressure injury in this area or most moisture associated skin damage in this area, has everything to do with the location. So within the gluteal cleft, or people like to call it your line between your buttock cheeks, if you see any discoloration or any opening in that line, most likely it's related to moisture. However, there was always a however. Her coccyx is going to be roughly in this general area here. The coccyx is one of the highest areas that you will find pressure injuries in adults. So if you see discoloration, you're actually going to press down on the area and see if you feel that bone that's underneath it. Now, in saying that, because we move our patients up and down and sometimes the skin goes with it and doesn't go back to its normal place as we are normal elastic, and so sometimes pressure injuries can be a little off center, but if I can palpate it anywhere near that coccyx, I know that it's pressure related. And it's very important to document that location, what it looks like, what the color is, and so you have it really good within your chart. And also then, if you're the one who's staging, you can go back to the pressure injury stages, make sure you're staging it accurately, or if you're not the one who's staging it, call that team in who's going to be able to come and to look and to stage that area for you. But spend some time in this region, because this is the highest area of pressure injury occurrence in teenagers and adults. So then we're going to move up her back. One of the things that I have seen for those who may be compromised is on the spinal processes. Make sure you look at the spinal processes, because if they are very visible, hers I can palpate, but I have seen pressure injuries on spinal processes, and you want to make sure that those are not there. Okay? Up the rest of her body, I'm going to open up her gown, and I'm again going to look at her back and see if she's got some discoloration. And then we're going to look at what is there, anything that could be pressure related, or is there something else going on. And then the last thing I'm going to do is I'm going to look at her scalp. Now again, if she had on a C-collar, at this point we would have somebody help us to remove the C-collar to the back, and I'm going to look at all those areas that the C-collar touches. And then I would actually be very concerned about her occipital ridge. So within your hair, we have right here on our scalp, there's a ridge line, and this is where we rest our head when we're in bed. And on this area is a very common location of getting pressure injuries when you haven't been moved in bed. I'm going to have a turn back over here into a supine position. And that is your head to toe skin assessment. From the top of her head, we went all the way down to her toes. When she got turned over on her side, we had her come back. Now, if this had been my patient, I would have made her comfortable on her side. I would not have brought her back into the same position, and would make sure that she'd been on that side for at least 2 to 3 hours. So thank you so much for being here today and for listening. I truly hope this helps.
Thanks very much, Anne-Marie. We're going to come and listen to some tips and tricks for the audience now from you. Now, you've honed these in from many years of experience, so we're looking forward to hearing about additional tips.
One of the most important things is lighting. Lighting is crucial when you're in the room. A dim lighting and also a flashlight will create shadows. And if you're looking at those shadows with a darker skin tone, it's just not going to work. There actually distorts the underlying tones that are there with someone with a darker skin tones. The best thing to have is actually a really good overhead light. I know so many times I walk in the room, they'll go, "Oh, just open up the window, the shades for you. You can see better." It's not the best. As much as I love sunlight, when you're doing a skin assessment, the overhead light is actually the best thing that you can do for them. The other thing with someone with darker skin tones, before you start that, especially if you're doing a bath, great time to do the skin assessment. If they have not had a bath in a while and their skin becomes very dry, they actually have white patches on their skin. I wish I had a good picture of that. I saw it the other day in a patient's room and I thought, oh, I should have taken a picture of that and added it. So they have these whiter patches, and if you talk to someone who has a darker skin tone or skin of color, they will call them ashy. And that's just the word that they use colloquially to show that they have these white patches on their skin. In order to get rid of them, they need lotion. How many times have you gone in and what they're using is actually either Vaseline or an Aquaphor component because it actually moisturizes their very dry skin. And so you're going to want to make sure that as you're doing this, if you need to use a moisturizer, have one there and ready to go because it's very important when you're looking at hyper or hypopigmentation that they've been moisturized and so you can actually see the differences within their skin tones themselves. Then I'm going to move down to the neck. And the biggest thing with the neck is a couple of things, especially if you have a trauma patient, they're going to come in with a C-collar. Another reason why you need those extra hands in the room. So if they're in that supine position, make sure you're holding that neck. You want to make sure we're not moving our patient out of alignment. Gently remove that collar. And then we're going to look here. But below the chin is a beautiful place for pressure injuries. It comes back. Look at those ears again. Make sure. And up here in your collarbone is where it rests is. And you want to make sure that you're looking that there's no erythema, no excessive moisture. We're not trapping moisture in the area. And while you're there, before you put that collar back on, go get that prevention measure, that prophylactic dressing that you brought in the room, and go ahead and put it down. So we're going to protect at the same time as we're doing our skin assessment. Trach. Trach is a beautiful site. We always have moisture there. I don't care what you do. It is a hole that we have created and is very lubricated. So lots of secretions are always at the trach site. So you know you've got that moisture already there. Not only look around, top, bottom, you want to look at that flange. I've seen too many there because that's where we put in the trach straps. And then it sits tight against our skin, making sure you're looking here. And we're going to look all the way around on either side of the neck to make sure that our neck is clean and dry. And when you're doing that trach change, we're supposed to be doing our trach tie change twice a day. And make sure you're cleaning that skin. Soap and water is beautiful. Dry it and put it back on in prophylactic dressings as necessary. We move into the waist, the groin, and the perineum area. Of course, there are many different types of briefs, nappies, diapers. Everybody uses a different name that we're going to have in that area. But what I find consistent is they all have elastic. So whether you've got elastic that hits in the groin, so we go right in here, it could be very tight, or you've got some sort of strap or elastic in the waist area, remove it. Look, how tight is it? Because if you are sedated or you may happen to have a spinal cord injury, sometimes we are spastic, we have spastic quads, and so your thighs are extremely tight. And because those thighs don't move apart very easily, that elastic gets trapped and it presses into the skin. Lots of moisture there, right? So we end up having pressure injuries within our groin area. You also want to be able to find if you have a Foley catheter. follow that Foley catheter tubing. In the room actually on Monday, unfortunately, I've got a patient who has got generalized edema, and you could see very clearly a female coming out of her Foley catheter. It actually pressed into her groin area. You could see it very clearly, creating a stage 1 pressure injury. Always follow that tubing, see what's going on, and making sure that there's no discoloration anywhere. And if there is, prophylactic dressings are wonderful to be used in the area. The other thing you want to look for is, do they have a rectal tube? Because a rectal tube, as we know, depending on where it's positioned, actually can cause internal rectal wounds that are there from pressure or on the outside of the rectal tissue itself. Make sure that you're assessing it and you're looking at it. If the patient is incontinent, and that's part of the reason you're in there, go ahead and clean them up. Get your friends, let's get them all cleaned up, get everything taken care of, dry the skin. Now, at this point with clean and dry skin, we're going to do our second SEM measurement and go ahead and do that at this point. And again, make sure that once you've done that assessment in those 6 areas, you tell that measurement, that delta score, and have your friend write it down for you so that you've got it for later. Noticing that also, once that is done, you want to make sure that you have put any moisture barrier down that you need to, or if you're going to do a prophylactic dressing, you don't want the moisture barrier to the skin and the prophylactic dressing on top of the moisture barrier because it will not stick. So you would actually want to put down the prophylactic dressing first and then go apply your moisture barrier. If you walk in the room and when you've turned them over and they have a prophylactic dressing, go ahead and remove that dressing and do your SEM assessment at that point, and then you can put the prophylactic dressing back down. Always, of course, making sure you look for any areas of redness or discoloration while you're doing that. If by chance you do see that while you're there, and depending on your particular hospital setting, some of them just say note the color and what region that it is at, and then go ahead and get a WOC nurse consult for them to comment and to assess it to see whether or not we've got a moisture-associated dermatitis or we have a pressure injury to the area. But you're the one who found it, so make sure whatever is your hospital policy that you do document it when you go back outside of the room. The last thing that we're going to look at is the back of our head and move the hair around. And as you can see, unfortunately for this little guy that I took care of, he ended up with pressure injuries, not only for immobility, that's actually my hand. And if I had moved up underneath my hand, there are actually linear areas of eschar that were actually from the C-collar. So he had 4 areas of pressure to the back of his scalp. The 2 that we're looking at were from immobility, and the 2 above, which we can't see, were actually from the C-collar itself. You've got to move the hair, especially those who have really dark hair. It's going to be difficult to see the eschar, and a lot of times it's just a feel. If you go up underneath there, you can feel that there is a difference within the skin itself that you're feeling, and know that something is going on there. Then kind of move the hair around to see what's happening. Many times the eschar, because it is a skin level, the hair follicles are actually, the hair is actually within the eschar itself. So you've got to be able to move it around to see what's going on. And then our 6th step in our skin assessment is go ahead and complete it. Make sure that that patient is comfortable. They're in a different position than when you walked in the room, and that you've checked all medical devices. You've put down prophylactic dressings as necessary or over the coccyx region. The heels are up off the surface or they're in boots. And you make sure as you walk out of that room, you document everything that you found. Get that SEM rating from your friend and your colleague that you were in the room, and make sure that's also within your chart, because that is going to be very important that everything has been documented. Thank you so very much for everyone being here today and for taking the time to listen to us and how important a good assessment and assessment tools are to protect our patients from pressure injury development.
Thank you very much, Anne Marie. That's really such an inspirational way to approach patient care, patient assessment. And I love the way that you're flagging up issues as you go along and treating them as you go along, which is really highly commendable. So thanks to you. And we'd love to hear from the global audience. Why don't you share with us how you do your assessments and whether you use SEM measurement and whether you'd be interested in learning more about how to do that in your own clinical practice. Let's go back to Kathleen now to talk about subepidermal moisture and pressure injury impact.
So what is the impact of pressure injuries? Well, when we look at it, if you're in the United States, we have about 2.5 million people treated annually in acute care for hospital-acquired pressure injuries. In the last international pressure injury survey, in the medical surgical areas, the prevalence was about 1.87%, and the incidence was 5.85% in critical care. Global ICU pressure injury rates. This was done by the Decubiti pressure injury study, which was a 1-day point prevalence that was done around the world. And you're looking at incident rates in critical care between 15 and 16.8% and prevalence between 25 and 27%. Global hospital-wide, I dug deep to try and find the data, 5.4% on the incidence and prevalence about 12.8%. So slightly higher worldwide. Needless to say, most severe pressure injuries are in the buttocks and the heels. So where does that tell me they are hanging out? In the bed, on their back. As a part of it. So, and this is in study after study after study. People die from these pressure injuries. There's significant pain and suffering, and there is, in our elderly population, there's a twofold increase just by being greater than 65 years of age for the development of a pressure injury. So this, you see the pain and suffering and the amount of injury that is taking place. What is it costing our healthcare systems? Well, and no pun intended, this is a cost analysis you can take to the bank because it was done by a health economics individual specialist on this. Cost of a stage one is roughly, stage one, stage two is roughly around $3,000. When you move to the stage 3 and stage 4 or unstageable or DTIs, that moves up to 71 to 127,000. Now in the United States, we're a fairly litigious society, and so there are about 17,000 lawsuits annually with the average payout between $250,000 and $500,000. And we know if we were able to provide the standard of care with those prevention strategies, it would actually cost less money than to treat the pressure injury and deal with the quality of life factors. So in the United States, it's costing our health system about $26 billion per year. So it's important to have a comprehensive pressure injury prevention program with risk assessment, skin assessment, support surfaces, repositioning to offload those bony prominences, prophylactic use of a dressing, heel elevation, and nutrition. But everything starts with a good risk assessment and skin assessment. So I'm going to talk about assessing the skin and how important early detection is, because when we detect things early, we can really hone in on those people that the offloading is critical, and they may need to be offloaded more frequently or never put in that position where their area of risk or injury has been identified. So in terms of assessing the skin, what does the science tell us? And this comes from the SPIP, from the National Pressure Injury Advisory Panel, which comes off based off of the guidelines to assess the skin. Comprehensive visual palpation, and you're going to learn more about that. And this is done upon admission and Q shift. And every shift, we need to be assessing under the nasal cannula, under the devices. If they've got a splint to hold their IV, we need to look at all of those devices. And the heels, because they are massively susceptible, we need to make sure we're taking those TED hose off if you're still using them and inspecting the heels Q shift. In people with darkly pigmented skin or people of color, one of the things you can do to improve your assessment is improve the lighting and moisten the skin, which helps augment some of the visual inspection. And then it's really important to consider enhanced skin assessment methods. And that would be subepidermal moisture assessment or thermography and using a standardized different skin tone chart so that you know what you're looking at as a part of that. So some of the challenges we face right now with early detection, identifying risk with standard tools, do they work for all populations? Now, in my perfect world, because that's where I live, and I want everybody else to hang out in my perfect world too, is if I'm using a risk assessment tool, I want to make sure it's reliable and valid. And in the United States, we use the Braden risk assessment tool the most. But for me, what is more significant of using that risk assessment tool is to actually use the subscales because they're far more predictive and they can drive interventions based on those risks. The visible and tactile skin assessment is considered the gold standard. You need to do it absolutely. But pressure injuries often develop in the deep tissues first, so we don't visually see it. It may not feel different, may not have a different color, may not have a different temperature. And so it's really clear to understand that visual assessment is not sufficient to detect the damage until the skin tone changes, which is too late for us to do anything to potentially reverse the injury. So visual assessment is also challenging with darkly pigmented skin, like I shared with you. So we do have some data on that. This was a study looking at pressure injury rates in darkly pigmented individuals from 2008 to 2012. They had there was about 670,000 cases reported with stage 3, stage 4, higher rates in men, higher rates in African Americans, and 2.4% higher rate of pressure injuries compared to all other races with a darkly pigmented skin, as well as having a higher mortality rate. So what the data is showing us with different colored skin or different pigmented skin other than a more pale pigmented skin is that we're likely to miss stage 1 and deep tissue injuries. That's what the science is telling us. And that's what this study told us. Stage 1 and deep tissue injury are the toughest. This was 96 African Americans with 274 pressure injuries. 32% were stage 1 and 67% were DTIs. Literally, those getting missed as a part of it. And so difficult to see. And there was a large variation in the presentation. 70% had some purple, 14% had some gray, 10% had some black, some brown. So it really made it difficult to be able to assess the presence of a DTI. So really the concept of these enhanced assessment tools is getting under the skin, being a detective, using technology for earlier detection of pressure injuries. So let's talk about what is happening underneath the skin physiologically when the cell has sustained pressure, shear, and tissue deforming. So let me get that. So here's our cell damage. So we start to have some cell damage because of the pressure, because of the shear. We then have some cell death. Then some inflammation occurs as a result of it, and we have leaking of fluid out of that as part of the inflammatory process, which then leads to edema. And that edema increases the interstitial pressure, which then squeezes vessels around, so causes further ischemia, leading to further tissue death. And so you've got this whole leading to tissue deformation. So the concept here is damage can occur 3 to 6 days before you see the breakdown on the visible skin surface. So we can use the opportunity to capture early when edema is happening to be able to identify those patients at risk. So clearly, this piece of it is not visible. This isn't visible unless you use technology. And over here, it becomes visible, but it's too late. So this is then a breakdown of going the microscopic to the macroscopic edema. So when you have this damage and you have a reaction that occurs that says, let's get more blood flow to this area. The blood flow results in the inflammation process, increased permeability, fluid released into the tissues. That additional fluid and that inflammatory process attracts the WBCs to the site of the injury. It can then lead to an inflammatory response if it goes systemic. So not just a localized inflammatory, this can also move to a systemic, and this is where you may also get sepsis, higher levels of white count, higher levels of so the WBCs, the fever, and the other signs and symptoms of sepsis. So the guidelines, the 2019 guidelines, and this part of the guideline, the skin assessment hasn't been the update of it for 2025 hasn't been released yet. I keep on checking the website. It'll be released between now and I believe November. So it recommends consider using a subepidermal moisture edema measurement device as an adjunct to routine clinical assessment. And the strength of the evidence is a B2. And the strength of the recommendation would be classified as non-specific. And then it also says when assessing darkly pigmented skin, consider assessment of skin temperature or subepidermal moisture as adjunct strategies as part of your assessment. So you saw that I mentioned thermography. This is an example of being able to identify. This is a visual and infrared that captures present on emission where the DTI was not necessarily visible to the naked eye, but you could clearly see the significant temperature change that was taking place. So the detection of pressure injury by identifying early temperature changes in the skin can indicate tissue damage when we see it. The infrared imaging, it emits an infrared radiation, which is captured by the thermal imaging camera that then gives you this image as well as the temperatures. And the areas of potential injury may appear cooler on the thermal image due to impaired blood flow going to that area compared to, and you always do a comparison to healthy tissue. And you can see that 0.1 degrees centigrade cutoff temperature determined pressure injury risk. So you're going down here is your cool colors. And roughly the science is showing that this temperature change shows up about 48 hours sooner than the visual that you and I see. Now, the other technology is subepidermal moisture monitoring. So what does that do? Let's walk through it. The moisture level of the subepidermal tissue is measured using an electrode structure placed on the surface of the skin. Low amplitude signals are used to assess the level of fluid in the epidermal and the subepidermal tissue. And then the fluid in the tissue as I shared with you previously, is part of that inflammation process that is happening as a pressure injury is beginning. And the amount of fluid is an early indicator of this tissue damage.
Oh, that's great, Kathleen. Let's show the global audience how to do an SEM measurement.
So now we're going to show you how to scan a patient. In this first scenario, we're going to scan the left heel. So we select the left heel, and the scanner is now ready to use for your patient. Always ensure the surface of the skin being assessed is clean and dry before you start the scanning process. Apply the sensor head flat against the patient's skin in the area to be scanned with sufficient pressure until the scan is triggered. When a scan is triggered, the scanner will flash blue and emit a short audio tone. Here you can see we're scanning the back of the heel, and you will see the blue flash as the scan is triggered. Next, we'll scan the lateral side of the heel, and it's very important when you remove the scanner from the skin that you lift it cleanly off and do not drag it. Next, the medial side of the heel, and again you'll see the blue flash as the scan is triggered. And finally, the heel pad, which can be omitted if the patient has heavily calloused heels. In this scenario for the left heel, we've now completed our 4 scans, and the delta reading is shown in the large circle. You can see that the delta reading is below the 0.6 cutoff and is colour-coded green, which suggests for the left heel, the skin is at reduced risk of pressure injury. In our second scenario, we're going to scan the sacrum. Again, you select the body area, and the scanner is now ready to use for your patient. You complete 6 readings at the positions shown in the figure to the right. Our 6 scans are now complete, and in this scenario for the sacrum, you can see that the delta reading is above the 0.6 cutoff and is colour-coded orange. This suggests that the skin at the sacrum is at increased risk of a pressure injury, and you should start or alter your preventive interventions. To review all your readings, press the body location screen and make sure that you plan to document them or to upload them to your electronic health record by placing the device into the charging hub. When you've finished scanning your individual patient, make sure that you remove the single-use sensor and clean the device thoroughly according to your hospital protocol.
Kathleen, can you share with the global audience how you analyse the SEM measurement numbers and figures?
So if I get a subepidermal moisture reading of greater than 0.6, it's considered high or abnormal. And I obtain multiple measurements in the same area to be able to get what is called the delta change, to be able to tell me if I am in that greater than 0.6 range, and that tells me I got something going on. And I will share with you, I know organizations in my country are using this in emergency rooms to evaluate present on admission, that there is some injury taking place already before they ever entered the building or the hospital. So biocapacitance is an electrical property of the tissue that varies with the amount of interstitial moisture content. Remember, we talked about how that moisture content develops. The greater the interstitial moisture, the higher the biocapacitance of the tissue is. And the higher that is, this is then interpreted by the scanner. So you can see the scanner. It's pretty easy handheld device. And when we get a SIM delta from multiple readings greater than a 0.6, it suggests the increased risk and that there's likely going to be injury present. So this was a systematic review of the literature of 17 studies looking at subepidermal moisture evaluation to identify pressure injury development. And what they were able to identify in this, that there was a consistent abnormal deviation in the SIM measurements that corresponded with the evidence of a visual pressure injury development. And what excited me about this is that the detection by the SIM measurement occurred roughly about 4.5 days before the visual showed up. So that gives me good warning to be able to offload that pressure significantly, but also that concept of present on emission. So PI development was clearly earlier than visual inspection. When this was used, there was a 93% reduction in pressure injury rates when staff responded with preventative strategies, augmented preventative strategies to this abnormal SIM measurement. The range of sensitivity is about 48 to 100%, and specificity ranges between 24 and 83%. So when we look at this, this is the way my brain thinks. I want to detect early. So literally, the SIM delta is giving me 5 days earlier in my detection of at risk or the development of the beginning development of injury. And then it says, if I have this raised SIM, it's like that pre-stage 1 we talked about, and I'm going to offload or not even put the patient in that area or positioning. And we want to treat those raised levels of SIM because when we do, we can achieve a 3-fold reduction in pressure injuries. And then ultimately, this can help us prevent pressure injuries by putting those strategies in place and knowing and continuing to measure and identify risk for our patients. So I want to thank everybody for their time and attention.
Thank you very much, Kathleen. That was a really wonderful start to this masterclass. I was wondering if I could ask you a question myself. Kathy, you mentioned this fantastic kind of opportunity, this golden window of several days before actual visual signs of a pressure injury develop. As a sort of clinician that's watching globally now, watching this masterclass, what can they do during that golden window of opportunity? Currently, what would you advise that they do during that golden window of opportunity to kind of bring into their clinical practice this opportunity to prevent these really devastating pressure injuries?
So, so let's just take an example that I identified this in the sacral region. One, the patient would never be placed in the sacral region in a routine change of position. I may increase the frequency of that offloading or making sure I'm using a shear friction device underneath them with wedges to be able to ensure an effective offload. I also know that if that sacrum is at risk with this, it's likely my heels are going to be targeted as well. And so I'm going to put boots on if the patient's immobile. The other piece I can think about doing is a protective sacral dressing, protective heel dressings if they're agitated and moving around to help reduce, excuse me, some of that shear and friction. And the other component to this is because injury is already happening, I'm going to take a look at nutrition as well and see what's happening around nutrition and my overall skincare.
Great. And can I just open it up to the rest of the panel? At what points would you recommend introducing SEM measurement in a patient that Kathleen has described there? Where would you, perhaps I'll come to you, Ruth, on this one. In terms of SEM measurement, at what points would you consider doing those in that patient's admission in hospital?
Yeah, in my opinion, and I think what the literature really bears out, especially with the clarity of this early detection device, it is a device that should be used with your ICU patients on day 1. And the question is, do you do it once a day or do you do it twice a day? And there's opportunity for research there to really refine that. But absolutely, you should be doing it once a day. And that will help you to know, are you actually effectively offloading? Beauty of this device is it will let you know that, hey, I think I'm turning them adequately, but maybe I'm really not. Their SEM is elevating. And it gives me opportunity to monitor it over several days to see,
is that coming down now, or is it staying the same? Do I need to be more aggressive with an intervention? So I would argue every day, and in some patients you may be interested in doing it twice a day.
Well, and I also think, Ruth, you have the opportunity pre and post OR,
For sure.
specifically the patients going to the critical care area. And I don't know if other places around the world have boarding issues in the emergency room. I suspect they do. I don't think in the US we're alone in that journey. I think this may actually need to think about moving into the emergency room.
Absolutely. And, particularly in UK and Europe, there are patients that are spending a long period of time on hard corridor trolleys. And those are patients that are high risk that may not normally be high risk had they not been put into that situation. And there's patients undergoing high risk surgery that also would be in that group of patients that it would be good to do an early SEM detection on. We'll come over to you now, Ruth, to hear about the evidence for SEM measurement.
Well, thank you so much for giving me the opportunity to speak today to this global audience about subepidermal moisture and as an early detection device for pressure injuries. And I think what we've done is moved into a science where we've moved from subjective determination of a really critical situation to objective measures. And I think that's fabulous. So I'd like to start out again. I have some objectives. I want to make sure that we really understand the foundational events that trigger pressure injuries, because that's the foundation for the science that subepidermal moisture is built on. And I also want to point out the disparities that exist in the epidemiologic profile of patients who develop pressure injuries. Again, that's going to emphasize the significance that this device can make to our healthcare outcomes, our patient outcomes, and describe the relationship between tissue capacitance and subepidermal moisture with the risk of pressure injuries. And then finally describe the clinical application of subepidermal moisture measurement. You saw this illustration before, and I think what I would like to point out with this cycle of the precipitating pressure injury is a concept when I've been in pressure injury prevention and skin care since the early 80s, and we were really emphasizing blood vessel occlusion and arterial occlusion. That's what our focus was, preventing arterial occlusion. And what we've discovered is the actual danger is the tissue deformation that occurs. That's the triggering effect, because those tissues, the cells become distorted, they rupture, they develop death, and as we've already heard, they release toxic cellular contents into the extracellular space, causing inflammation. That inflammation then triggers more perfusion to the area to deliver healing elements and chemicals to the skin. That then develops more poration of the capillaries, so that you have more edema formation. And that is where we're going to find the early detection and a biomarker for pressure injuries, that early microedema that develops deep into the subcutaneous tissue. We then proceed on with more interstitial pressure because of that fluid, because of all the blood vessels. We have then ischemia that's developing because of the occlusion and the pressure against the blood vessels. So now we have ischemia developing, and we have, in addition to that, the lymphatics are occluded, so we're not having the drainage away from that damaged site. We have increased cell death, and then the cycle continues all the way around. And for some of us, those diagrams aren't as useful as just listing out, a bulleting out of the factors that contribute to pressure-induced cell damage. So I spell them out here, and just to help kind of underscore the significance of that cycle. And what we want to do is interrupt that cycle. And we have the tools now to be able to interrupt that cycle. Our standard of care has been around for years. We've probably had our first standards of care for pressure injury prevention in the early 90s, and they've evolved over the years. They've been enhanced and further developed and detailed. And key cornerstones to current standard of care for pressure injury prevention is the use of the risk assessment tools, as we've already described, and the use of visual tactile skin assessments, key components to pressure injury prevention, because we want to identify who's at risk and identify if there's the extent of the condition of the skin as we currently see it. The downside of these devices, of these strategies, are that the risk assessment tools were developed years ago, and they don't account for several risk factors now that we know put our patients at risk, particularly in critical care. And we also know that they have very high, very variable, inter-rater reliability. So if I do a score on somebody and somebody else has a score, we may or may not really align in our determinations. So they're just subjective, but they're good tools, but we have to augment them with our understanding of the other risk factors to consider. So it relies a lot on the clinical caregiver to really do a thorough risk assessment. And the visual skin assessment, again, it's subjective. The reliability of classification is inconsistent because it's really easy to get it confused with MASD and viral ulcers and bullous disease and ITD, all those confounding conditions. So it takes a trained eye. It's also difficult to identify blanching versus non-blanching. Again, we need a trained eye. But in addition to that, once you see the non-blanching erythema, the damage has already occurred. So you're kind of late. You're kind of behind the 8 ball now, and with that visual skin assessment. But even more importantly, it's difficult to identify color changes in people of color. So these are not, I'm not advocating we throw these out at all. I'm saying we use these, and remember they're cornerstones, and we augment them now with our early detection devices. I want to speak just for a moment about dark skin tones and the disparities in pressure injuries. And I broke these down into several categories where there is disparity. First of all, the prevalence and incidence, which we heard Kathleen talk about. It's 1.7 to 2 times more likely to occur in people with dark skin tones than in people with light skin tones. And that's been reported over and over again. The severity of the pressure injuries are also dramatic. Their higher stage injuries are more common in people with dark skin tones than in people with light skin tones. And conversely, there's fewer stage 1 pressure injuries in people with dark skin tones because we missed it, simply. So they have more severe pressure injuries when they're actually identified. And in addition to that, the time to develop a pressure injury, patients with dark skin tones develop a pressure injury in less time than patients with light skin tones. And why might that be? Again, because we're late in really recognizing the condition of the skin and what is going on. These differences, these disparities occur across all healthcare settings. So it's not unique to critical care or the hospital. It happens in all the healthcare settings. And what I wanted to point out with this slide is that how long have we known about these disparities? We've known about them a long time. Look at this. Dr. Bergstrom first described it in 1996. And then this is just in order of the years, a number of times we've observed this going on. And so to me, this is a call to action. We didn't have the technology to really address these disparities for many years. What we did is we tried to identify better ways or more ways to describe what a pressure injury might look like in the people of dark skin. We started saying, okay, let's moisturize their skin. Let's use the back of your hand or instead of the palm to detect temperature changes. Talk to the family member to see if they think there's a difference in the skin color and does this look normal. So we started doing all these things to try to improve our assessment techniques. Again, they're all subjective. And now we're in a situation where we can really tackle this with objective early detection technology. So I love this slide that Dr. Moore put together to describe where we are currently and what we're trying to get at. And so basically what we do at the current state is we're looking at the skin level, and we're looking at visible changes in the skin, and we're looking for tactile changes. This is our manifestations threshold. So we're seeing what happens at the skin level. Then, but what we'd like to do is move to this window of prevention, this next level. That's where there's already some subepidermal tissue damage. There's a vascular permeability going on that we already described, some interstitial fluid accumulation, the microedema is going on, microscopic edema is occurring. And that's where we want to move to, that early window of prevention. We want to move there before we get to the damage threshold. So, and that's where the toxic metabolites take over. We have lymphatic dysfunction, nutrients are depleted, the inflammatory process increases and is amplified. So our goal is to move from assessment at the skin level to down below the skin level into the window of prevention. This is a report that was done by Dr. Scafidi, a systematic review. There's been several early detection devices described in the literature. And so her study was to look at a review of eligible studies to identify which had the best literature to support its use. So she, in 2020, she found 18 eligible studies. She looked at ultrasound, thermography, subepidermal moisture, and the spectroscopy and laser Doppler. And what she found was that the subepidermal moisture measurement provided the most consistent findings in the early detection of pressure injury. And so this is just to say that these other techniques exist, but what subepidermal moisture has when you're looking at these devices is they have more literature, more research at a higher level to demonstrate the impact of this device and its clinical utility. Other devices have a role. They may just not have they may just be working on improving their science to support the utilization and the bedside clinical application of them. So basically when we're looking at subepidermal moisture, the concepts are that subepidermal moisture has a consistent distribution in healthy tissue. And we already know this because we know with wound healing, all the tissues are bathed in moisture, and where our goal is to provide a moist wound environment. So we know that there's a consistent distribution of moisture in healthy tissue. What we know also is that localized tissue edema, that microscopic edema, results from injury to the cell and tissue, and that this is the earliest sign of cell death in pressure injuries. So, and this is this coordination with pressure injuries, stage 1 pressure injuries, is thanks to the research done by Dr. Barbara Bates-Jensen. We also know that tissues have this capacity that is dependent on water content. So the more water they have, the more conductive properties they actually have. And changes in that measure of capacitance can be correlated with physiologic events like inflammation and microscopic edema. And again, this is thanks to the research done early on by Dr. Barbara Bates-Jensen. So these fluctuations in subepidermal moisture are indicative of tissue damage, and we can now measure that, and now we can act on it. And I also just wanted to point out that ICD-10 code L89 defines a stage 1 pressure injury as a pre-ulcer skin change limited to persistent focal edema. So the concept is already recognized and in our ICD-10 codes of persistent focal edema or that microscopic edema. So what's this scanning technology look like? How's it function? It's a handheld device. That's what's unique about this technology and really salient in terms of how it's used. It's used at the bedside by caregivers. You can train the caregivers to use it. It's non-invasive. There's no radio frequency energy or current that passes through the body between electrodes. and it penetrates for a depth of up to 4 millimeters. And the relationship with pressure injury damage has been demonstrated with several devices, several types of subepidermal moisture monitoring devices across anatomic locations, among multiple patient populations, across all skin tones, and in various healthcare settings. And we've had consistent findings with all those variables. The FDA has approved this device for detection of the sacral and heel pressure injuries. And often there's questions about, well, why not use it on the occiput or on the trochanters or on the ITs? And currently it is supported for sacral and heel pressure injuries. And those are as we saw with Kathleen's research presentation, that the predominant number of pressure ulcers occur in the sacrum. So there's good reason to be using it for those sites, and why the company would focus on those sites. This is an example of the procedure for obtaining the subepidermal moisture scores, or the readings. Again, we're looking at the sacrum and the heels. And in the sacrum, you're going to obtain 6 measures, and you'll do it right over the bone, and then 2 to the left, 2 to the right, and 1 just slightly above the sacrum. And what we're doing is measuring the amount of moisture over the bone and around it. Because remember, we're saying over the bone is where the damage is. So that's where that microscopic edema is. Surrounding the bone should be more normalized. So we're going to look at what the difference is in the moisture content between those sites. And the device actually helps measure what that difference is, that delta score. And through their research, they've been able to determine that the threshold cutoff score is 0.6. So that 0.6 or greater indicates there's an increased risk of a pressure injury at that site, and 0.6 lower than 0.6 means that they are at a lower risk for pressure injury at that site. The technique is fairly simple. You just hold the device over the designated sites for a very short period. They immediately registers a number, you hear a beep, then you move on to the next site. There's 4 measurements done on the heels. It takes a little training to be really clear on where you need to go on the heels, but you also, the way the device, the readings that you get, you can be trained, or you can be taught that certain scores just are not logical, so you would remeasure them. So there's training involved, but it's really pretty straightforward. So the question with subepidermal moisture measurements becomes, what should the use look like? What's the routine use? And this is the recommendation that's coming out of the National Pressure Injury Advisory Panel that they announced at their annual conference in February of this year. That SEM assessment should be conducted routinely in high-risk populations to identify preemptively skin at risk of breakdown. And the explanation is that the SEM technology detects tissue changes up to 10 days before visible damage occurs, allowing for earlier interventions and better patient outcomes. So the recommendation is to equip facilities with SEM devices and provide training for their use as a part of a comprehensive pressure injury prevention strategy. So notice that it says as a part of pressure injury prevention strategy. So it is a partner with your risk assessment tools and with your skin assessment. Then you would also do this routine subepidermal moisture measurement. So the research surrounding subepidermal moisture has focused in different issues. And one of the issues was time to detection. It was really important to determine really how well does this device detect pressure injuries compared to visual skin assessment. So I was lucky enough to participate in this particular study, and where we looked at the gold standard of clinical skin and tissue assessment and subepidermal moisture measurements in the ICU or in patients who were at risk for pressure injuries. And what we found is that the subepidermal changes occurred 4.74 days before visual skin assessment. And what was So that's really stunning to me because that gives you opportunity to intervene. But what's more stunning to me is the number of pressure injuries that occurred in this study. This is a study where we're watching the patients every day. There are two different people looking at somebody's doing the subepidermal moisture measurement, and different study person is looking at their skin and doing an assessment. And yet, even with that close scrutiny, look at the number of pressure injuries that developed on the sacrum and on the heels. So that tells me not that we're not doing our job. It tells me that we really don't understand how complex pressure injury formation is. And that's why I feel like it's so timely now that we're beginning to develop objective measures and not relying, and that we can use in addition to our subjective measures to determine pressure injuries and intervene early. We've also, another avenue of the research is looking at sensitivity and specificity, because you need to know that you're actually measuring what you're thinking you're measuring. And Gershon and Okonkwo really identified this early on. They looked specifically at patients with confirmed pressure injury or suspected deep tissue injuries, and they compared them to confirmed healthy tissue unaffected by pressure injuries. And they reported a sensitivity of being able to distinguish between healthy and damaged tissue, and the sensitivity was 82.2%, specificity 51%. And then even more recently, Dr. Bayumi had conducted a descriptive comparative longitudinal study, and again in the ICU patients who were intubated. And what they did is they compared SEM scores to the modified Kubin and Jackson scale, MCJ scale. And they had an independent rater for MCJ and an independent rater for the SEM scale. And they measured patients for 6 to 21 days. And they were able to report the sensitivity for the SEM is 89%, specificity 77.8%, MCJ in comparison, a much lower sensitivity, and even reported the negative predictive value of 84% with SEM versus 53% with MCJ. Now, the risk assessment tools are not meant to be predictive. They're really meant to capture the condition of the patient. But nonetheless, I think these values are really, again, important to arm yourself with when you're going to go to administration or whoever you have to go to encourage them to purchase and buy into this new intervention, new assessment tool.
A really important aspect of this is the clinical implementation of SEM measurement, isn't it?
So the next area that has been researched by about subepidermal moisture is the clinical implementation. So you have this score, but the question becomes, so what? What do you do with that value? Many people believe they're already intervening in a preventive manner. So what will this give me? And what this particular slide demonstrates is that in this accumulation of different patients in different settings, before they implemented subepidermal moisture, they had 52 patients per 1,000 with a hospital-acquired pressure injury. And then after they implemented SEM, that number went down to 5 people per 1,000 with hospital-acquired pressure injuries. So a 90.5% reduction in the number of pressure injuries. And what's interesting to point out is this occurred in acute care, in community care, and also in hospice care. So it gives us evidence that pressure injuries don't have to occur even in hospice patients, that we need to change our mindset. In addition to looking at clinical implications and how do you use it, the so why of clinical implications, it's important to look at how do nurses respond? What's the response of the caregiver when you get a reading? What do they do? And in this particular study, this is a 950-bed hospital, and they had more than 200 pressure injuries in the past 6 years, and they had per year in the past 6 years. And they were looking at what are the interventions people have used in the ICU and in the orthopedic unit. And what I want to point out, in the ICU, looking at just SEM delta scores, no visual skin changes, they had 18% with an elevated SEM. Those who had elevated SEM and visual skin changes was 12%. And so this 18% would have been ignored if we relied just on the visual skin assessment. So we're increasing your catch of people at risk for pressure injuries by utilizing SEM. Now, what did they do when they found that? They act. The caregivers are acting on that information. They increase their turning and mobilization. They're already probably on specialty beds in the ICU, so they didn't change that. And they also elevated the heels or gave attention to the heels. So that's in the ICU. In the orthopedic unit, again, they had 27% of patients who had an elevated SEM, but no visual skin assessment changes, while they had 4% who had concurrent elevated SEM and visual skin changes. So a total of 31% were identified at higher risk. And what did they do for interventions? They motivated to intervene, and they had more turning and mobilization. They looked at their support surfaces and modified those, and they addressed the heels. So the people are acting on this information, and that's a key component of why subepidermal moisture is so successful. This particular study I was really interested in because this is a study done by Chambers and Thompson, and they looked at pre-implementation, again, retrospectively, for 12 weeks, and they looked at post-implementation of the SEM score, 12 weeks, over a 12-week period. And their intervention between pre-implementation and post was to do the daily SEM, and then to act if the visual skin assessment or the SEM was elevated. They had anatomy-specific interventions already identified, but they included consultation. So it wasn't just the staff responding with doing more interventions for that particular site, but they also consulted with wound care. They consulted with the physician. So the physicians were on board and knew what was going on. They had nutrition come in and do their work. So again, elevating the value of pressure injury prevention to make it more recognizable within the healthcare team, with physician groups, with nutrition, so everybody's responding, not just the nurses doing, changing positions or doing interventions for the site, but everybody's responding. And they had their results where the pressure injuries dropped from 8 per 90 to 0 per 50. And their relative risk of hospital-acquired pressure injuries was 1.6 times higher in group 1, so the pre-intervention group. So to me, what came out of this was, again, the pre-implementation, post-implementation shows us there's a difference, but it also describes the intervention as more than to be more inclusive, multidisciplinary, which I think is really important. So the question then becomes, okay, we have clinical application. How do you do this? When do you do it? How often do you do it? And the frequency of assessment that I recommend and that I think bears out in the literature, and there's more research being done on some of these frequency of assessment determinations, is that admission and discharge, bare minimum admission and discharge. Any patient coming in, especially if they're coming from long-term care, especially if they're coming from another institution, and a discharge so you can validate that your patient is leaving and not having leaving with a condition that you might have that you could be charged with having occurred on your watch. In the ICU, daily to twice daily, and pre and post-op. And some people are using the post-op to go. You might have parameters around how long you do the post-op, but some people are doing the post-op for 3 to 4 days because you begin to see that trajectory coming down over that time period. But really, your frequency assessment is going to be guided by your pressure injury rates the clinicals, the sites that you're in, risk scores, and the workflow of the staff. We implemented subepidermal moisture in our rehabilitation unit, and that was a big part of what we wanted to know is what did the nurses find would work well for them in rehab, because those patients are up and moving and having to have a tight schedule. And so incorporating the nurses and determining that workflow and the frequency is really significant and helps in the change of asking them to get this kind of work also done. And then the interventions that are based on the SEM Delta score, if it's less than 0.6, they're going to maintain their current prevention interventions. If it's greater than 0.6 or greater, then they're going to implement anatomy-specific interventions. They're going to reassess the interventions they're currently using because it might be that they're not being as diligent or they might not be as effective as they thought they were being. And they're going to ensure that interventions are adequately implemented and achieve additional consults. I really believe that holistic approach of involving the healthcare team is really significant. So the focus should be you detect, you treat, and then you prevent. That should be the sequence of events for how we would use the subepidermal moisture. And this recommendation for subepidermal moisture has been identified by the International Pressure Injury Guideline since 2019. Again, they consider using a subepidermal moisture edema measurement device as an adjunct to routine clinical assessment. And then the other recommendation was when assessing darkly pigmented skin, consider assessment of skin temperature and subepidermal moisture as important adjunct strategies. Again, that word adjunctive. It's not replacing risk assessment. It's not replacing skin assessments. It's an adjunct to those. And even further, the AORN, the Association for Perioperative Registered Nurses, and in addition, identifies the use of this technology to help prevent pressure injuries in the operating room. So in drawing this to a conclusion, what I want to summarize for you is why SEM monitoring. And essentially, there's many reasons, but I think these are the nuts and bolts of it. They enables targeted interventions, early interventions, while the damage is still microscopic and reversible, and therefore has the potential to prevent further damage. Number two, SEM technology detects tissue changes up to 10 days before visible damage occurs, allowing for earlier interventions and better patient outcomes. And I would say 3 to 5 days, but this is critical in that it gives you a window of time to intervene. And there is an 80 to 90% reduction in pressure injuries across all healthcare settings that have been reported consistently. This device eliminates the disparity in pressure injuries based on skin tones. A huge factor, huge motivation for why we should be doing something like this. And even more importantly than all of this, it reduces the costs and the patient complications and the adverse patient outcomes. Pressure injuries are significant. They cause increased risk of infection. They cause increased risk of sepsis, pain, death, all kinds of things. They're bad outcomes. And we need to be much more aggressive in trying to prevent these pressure injuries. So the call to action is that we need to recognize that SEM provides objective data to amplify our subjective data. We need to recognize that erythema and hyperpigmentation are late indicators of pressure injury, and that targeted interventions can reverse this tissue damage, and we can eliminate skin color as a risk factor. There's lots of research opportunities in this very exciting technology. We can learn more about other body sites where we could be using it. We could use more research to look at the clinical decisions based on SEM scores and look at the frequency of measurement based on the clinical setting, whether they're in the ortho or the ICU or the rehab or long-term care. So in conclusion, This is why subepidermal moisture is so critical. This is preventable, unnecessary harm, increases the risk of all these complications. We should not be satisfied when we intervene and our rates decrease from like 200 a year to 100 a year, or from 100 a year to 50 a year. That's still not okay. We still have people getting pressure injuries, hospital acquired, and we need to be able to intervene. And this is a device that we need to really promote and encourage in our systems. We need to be the patient's most vocal advocate for best practice in pressure injury prevention. We need to be pushing for this because it will cost money. There's a cost to it, but the cost to having a pressure injury is much higher. And we need to help our administration recognize that and own it.
So can I just come to you ladies for one last final kind of point? What do you think are the key messages you would like to give the global audience? So just maybe one each, if you don't mind. What a sort of key take-home message from this masterclass? And to come to you first, Kathleen.
Thanks. That's a great question. Or wanting to wrap it up into an important component. And for me, I hope you never have to stage. I hope you are able to prevent through the actions you take, through the augmented assessments that allow you to identify um, areas of risk early and then implement those prevention strategies so the pressure injuries don't show up and you don't have to worry about staging them. That's my hope.
That's a great one there, Kathy. And how about you, Anne Marie? What do you think is a key message for the audience today?
I think that sometimes because our nursing staff have so much that they have to do, I think for me, the key is to make this just a part of your routine and a part of something you do when you walk in the room. It should never be, oh my God, I've got to do a skin assessment. It should be just part of your flow. If you make it that way, this becomes something that is not tedious. It is something that you automatically do as you walk in the room, and you know the prevention measures, you know what needs to go down, and you just make it part of your daily care and you move on. So don't make it something difficult. Make it easier for yourself and make it part of your flow.
What high standards this panel has set for our global audience today. So fantastic. And Ruth, if I come to you also for your final kind of takeaway message for the audience.
Yeah, I think my takeaway is embrace the new technology. For many years, we used cyanosis of the lips or of the fingers to try to assess whether the person was getting oxygenation okay. And then suddenly we discovered these sensors that can detect the oximetry to detect oxygen levels. So we do those assessments, but we don't diagnose based on those. And it's time for us to make that same transition with this technology. So I think it's embrace the technology, and you're the driver with that. You can, firm up your determinations of the condition of the skin. And I think that's very empowering. So embrace it.
Yeah, and it's essentially moving from a subjective assessment that you've all mentioned and alluded to through this masterclass to a very objective measurement, which can actually guide you in that golden window of opportunity in the very early phase of the patient's clinical journey. So I thank all of you for joining us, and thank you to the global audience. Don't forget to stay tuned for the quiz, because you'll have a short quiz, and then your CME and CE QR code can be scanned, and you'll get the certificates very shortly. Thanks very much, and hope to see you for the next masterclass next month.